Hi, this will be your discussion on craniocerebral trauma and head injuries. So I'll be talking here about the possible impact of injuries to your cranial functioning and to your brain functioning. Okay, so class, these patients have undergone, okay, or this is a typical example of a patient who had a head injury. Okay, so if you would look at the signs and symptoms of this patient, the patient may have ptosis. Okay, the patient eyes is not open spontaneously. In other words, the patient is manifesting signs and symptoms of altered level of consciousness already. Okay, so your head injury may occur in any nature, but the most common ones that you may encounter is related to motor vehicular accident. Okay, other than that, other nature may be related to fall, and then you may also have injury secondary to mauling. Now, when I talk about craniocerebral trauma, this is an insult to the brain which can be caused by an internal or external physical force. Okay, again, external physical force. This results to diminished or altered level of consciousness. Okay, resulting to impaired cognitive, physical functioning plus disturbance and behavioral and emotional function. Okay, so the main cause of that is the insult to the brain related to the external physical force. Okay, for the signs and symptoms, okay, it's still related to your diminished or altered level of consciousness. And that would still be dependent on the part which is affected during the impact. Now, there are several mechanisms contributing to the head trauma. Okay, it could be in the form of acceleration. It could be in the form of deceleration. You also have deformation. And then you also have what you refer to as your coup counter coup phenomenon or injury. And then we may also have rotation. Okay, let's discuss them one by one. When I talk about acceleration injury class, okay, this happens when the head is struck by a moving object. Okay, for example, if the head of the victim was struck by a bat, okay, during a game, for example, accidentally, that is an acceleration injury. A deceleration injury is when the head is moving and then it hit a stationary object. Okay, for example, banging the head against the wall may result to a deceleration injury. Okay, so again, acceleration injury, the stable head or the static head is struck by a moving object, whereas on a deceleration injury, it is the head which is moving which struck a stationary object. Okay, so you also have the term class coup counter coup. So class, your coup counter coup is oftentimes referred to also as your acceleration deceleration injury. So this happens when the head hits an object and the brain rebounds within the skull. Okay, so there are two injuries that will occur. So one, okay, it would injure at the point of impact. That's why it's referred to as coup. And then class, other than that, for this example, you can see that the impact is on this side of the head. Okay, that's where the coup injury occurred. Now, it may also be possible that the other side of which will be damaged. Okay, the opposite side of the impact is referred to as your counter coup. Okay, so injury is occurring on both sides of the brain. So that is your coup, counter coup injury. In other terms, class, or in other references, they would define coup injury as a cerebral bruise, which would occur again when the head is stationary and will receive a blow. On the other hand, the counter coup injury would usually occur if the moving head hits a stationary object, and then the damage is found on the opposite side of the impact. Okay, so class coup, counter coup injury. Now, you also have your rotational acceleration. Plus, when I talk about rotational forces, this may be related to shearing or twisting. Now, the brain injury results from a trauma situation wherein the speed of the body is interrupted and unrestricted movement of the head occurs out of synchrony with the movement of the neck. Okay, in other words, class, it's just like your neck is turned to the right and then your head was forced to turn to the left. Okay, there is out of synchrony on the movement of the neck and the head. Okay, that's why it's referred to as twisting or rotational injury. Now, on the pathophysiology class, okay, recall that the external forces, okay, may result to diffuse injuries. Okay, these diffuse injuries class may jolt brain within the skull. Okay, the brain is moved inside the skull and the brain is pressed against the skull. That would result to shear cerebral blood vessels. Okay, shearing or damage to your cerebral blood vessels. Now, that could also result to the damage to the cranial nerve that would twist the brainstem and even your cerebral hemispheres. And here we're talking again about tissue hypoxia and ischemia, and then death of affected tissues. So it's hypoxia, ischemia going towards infarction. And then obviously you would have your neurologic deficits. When I talk about your neurologic deficits here, you'll have your paralysis, motor sensory changes, problems in balance and coordination, especially with the damage of your cerebellum, psychological and emotional changes if your frontal lobe is damaged. Okay, if you would come to look at it, class, the signs and symptoms are congruent with the one that we discussed in altered level of consciousness. Okay, one thing that's differing here, class, it's that the increase in the intracranial pressure is quick due to the nature of the injury. Okay, this may be brought about by accident, so it is quicker compared to those diseases who had pathologic basis. Now, there are several classifications for your craniocerebral trauma. Okay, 1, open. 2, closed head injury. You have blunt trauma. You also have penetrating head injury. And then you also have your primary head injury. Try to talk about them one by one. Okay, so class, you have here a CT scan image, okay, showing a patient who had an accident. Okay, now open head injury, as the term implies, class, open. Okay, the big word there is open. In other words, the object was able to penetrate the skull. Penetration of the skull would be possible if we are into dealing with accelerating objects and then sharp objects. So the tendency is that they would enter the brain and damage the brain tissue. The blunt trauma, class, could be severe. Okay, this may be caused also by a blunt trauma, which may be severe, that it opens the skull and dura, exposing the brain. Okay, the concern in your open head injury is that something is open, the access to the skin is open, which would increase, class, the risk for infection. Okay, increasing the risk for infection. But then, of course, infection will not be your primary problem here, but of course, the increase of your intracranial pressure. Now, you have your closed head injury. In a closed head injury, class, the head would accelerate and rapidly decelerate, okay, just like your coup counter coup earlier, or collide with one another, and the brain tissue is damaged. Okay, your big word there is that there is no opening through the skull and the dura. There is damage inside related to coup counter coup, but there is no opening to the skull or the dura. Next, you have your blunt trauma. Class, your blunt trauma may be caused by any of these forces. It could be a fist, it could be a ball, it could be a bat. Okay, bat, I mean. So, for any of those objects, class, blunt trauma, okay, may be caused to your head. That's why, for this reason, class, if you are engaged in these activities, we would usually advise the use of protective gear. Next, you also have your penetrating head injury. So, class, for a penetrating head injury, one example will be your gunshot wound. Okay, so class, on the CT scan image, you can see gunshot wound shrapnels. Okay, class, that have entered this site here. Okay, or possibly from this site here. Okay, and then it spread there. Okay, or it moved towards there. Okay, so penetrating head injury. Survival of a patient who had a penetrating head injury would depend, again, class, on the site which is first injured. Okay, but of course, if we're talking about head injury survival or gunshot wound to your head, survival is less likely. Okay, unless if the major organs or major parts of the brain were missed by the gunshot. Now, skull fracture. Of course, class, fracture is a break in the continuity of the skull. Okay, of course, common cause is still your vehicular accident. Then you also have your fall. Okay, in the clinical setting, the most common ones that you can encounter, again, is vehicular accident. Here, you can see the classification of the skull fractures. It may be open or closed, linear, comminuted, depressed, or basilar. Okay, basilar fracture is unique to our skull only, but the other types of fracture could be encountered in other parts of our musculoskeletal system. Now, when I say open fracture, obviously it's open. Okay, so the dura here is torn. When I talk about closed head fracture, the dura is not torn, it's still intact. Okay? Next, linear or simple fracture. So as the term implies, linear, meaning there's one line involved. Okay, as you can see on the illustration on the right, that's pointed by the arrow, that's an example of your linear or simple fracture. It's the most common type, class. typically extends from the point of impact from the skull. And then CSF leak for this patient is minimal. Okay, subdural or epidural hematoma may be frequent for these patients. Okay, so again, recall, because subdural hematoma could take about months to develop. So you need to monitor your patient again for deterioration, okay, or deterioration. Now, your comminuted fracture, when I say comminuted, the key word there is crushed and fragmented. Okay, it's considered to be crushed and fragmented. Okay, when I see depressed fracture, there will be inward depression of bone fragments. Looking at this image class now, the depressed fracture is again a result of vehicular accident. Okay, oftentimes I would encounter this if among drivers, and then I had one wherein a child was stepped on by a car, okay, by a running car. Okay, that's at the time you can observe depressed fracture. Survival of the patient is again very poor. Okay, unless class the vital parts of the brain are saved. But then class, if they are able to survive the accident with a depressed skull fracture, the tendency is that they will have residuals thereafter. Okay, due also to the rapid compression of the brain tissue and then the damage and then the ischemia. Now you have your basilar skull fracture. Was able to touch this in the earlier lectures. So class, when I say basilar skull fracture, okay, it is the fracture on the base of the skull. Common to this is your CSF drainage from the nose and then the ears. Okay, so for the nose, that is referred to as your rhinorrhea. Okay, so class, the presence of leakage, okay, or CSF leakage through your nose is referred to as rhinorrhea. Whereas class, for the CSF leakage from the ear, it is referred to as otorrhea. Now, how will I know that the fluid that is leaking from the ears and the nose are not the runny nose fluids, okay, are not your regular ear secretions, but it would be CSF. Okay, class, we have what we refer to as your halo sign. Okay, class, when I say halo sign, if you will be dropping, okay, if you will be dropping a drop of that CSF fluid leaking from the nose of your patient, you will observe that there will be halos that will be surrounding the drop that you had. Okay, so class, that is your CSF in which it separates its component. Okay, so class, that is your halo sign. Just drop the fluid in a piece of paper and then you would see that from the drop there will be halo that will be surrounding it. That would indicate that your patient's CSF is leaking through the nose or leaking through the ears. Is that something that we can be happy of? Of course not, class. If your CSF is leaking, meaning class, there is a severe injury on the part of your patient. Okay, so class, you can see this kid here with a periorbital ecchymosis. Okay, memory serves me well. This is raccoon's eye. Okay, so this is your raccoon's eye, which is a sign of your basilar skull fracture. Then you have the signs and symptoms. Oh yes, so you have your raccoon's eye as your bilateral periorbital ecchymosis. The second is your battle sign. Class, your battle sign is ecchymosis over the mastoid bone. Okay, then you also have your blood behind the eardrums. We refer to that one as homotympanum. Okay, so why is there blood behind the eardrums? Recall, class, that your eardrum is the one that separates our external ear, our outer ear, from the middle ear. Now, class, your middle ear would have access. Okay, so the middle ear will be able to access the site of injury. So because of that, class, you will observe bleeding behind your tympanic membrane. Okay, then you also have injuries to cranial nerve 2, 6, and 7, which is very common. So 2, class, is in charge of your optic. Okay, so if you have your 6, that would be in charge with your movement of the eyes. Okay, and then you have your cranial nerve number 7. Okay, there could also be injury to the internal carotid artery. And recall, class, that carotid artery is the major artery that would supply blood, okay, to our brain. So with that injury, we are anticipating, okay, that the patient would have difficulty of recovery. Now, class, so this is your battle sign. Example of battle sign. Okay, so collaborative management. What will we be doing for this patient? Okay, class, for the simple linear fracture, bed rest and observation for underlying brain tissue injury or hematoma formation. Okay, so in other words, the patient will just be observed. Okay, unless if the patient is having pain, okay, pain medications may be given. Okay, now, Class, they need to be on bed rest for recovery. But if we're talking about a simple linear fracture on the skull, okay, we don't need to apply splint here, class. Okay, try to think of the structure of your head. Okay, we are not anticipating on applying splint on your head. Okay, so class, for your simple linear fracture, no specific treatment is required. May send patient home after observation as long as you were able to educate the patient and then the significant others of the signs and symptoms that they need to watch out to, okay, or that they need to watch out for, which would indicate regressing or decreasing level of consciousness. Okay. Then for your depressed skull fracture, class, surgical intervention would be needed within 24 hours. The wound would be debrided, and then once the debridement of the wound is done, it would completely remove the bone fragments. Okay, so debridement of the wound completely to ensure that the wound is clean before you open up the skull for that matter. Now, you also have your basilar skull fracture. For your basilar skull fracture, class, the key for management is to ensure, okay, that there is no need for surgery unless, class, the CSF leakage would persist. Okay, these patients are given dexamethasone for the purpose that we want to reduce cerebral edema. And then we are talking about administration of antibiotics as part of prophylaxis. Okay, so now, since there is an open wound usually in your basilar skull fracture, you would administer your antibiotics, okay, and that is to prevent the occurrence of infection. However, class, if your patient would have infection, the surgery needs to be delayed. Okay, the surgery can be delayed for even up to 3 to 6 months. Okay, so if with infection, surgery is delayed. Now, the following nursing diagnoses are applicable for these patients. Okay, class, with hemorrhage. So you have risk for infection, especially if it's open, pain, okay, related to traumatic skull injury. Then you have your risk for ineffective breathing patterns that would be brought about, class, by the damage on your brainstem. And then risk for altered cerebral tissue perfusion. Of course, you're talking about hematoma here. Then you have your risk for ineffective thermoregulation, hypothalamic function, class. And then you have your altered thought process. Okay, so damage on the frontal lobe and the parietal lobe would lead to altered thought process. Another set of disorders or condition that we may want to know is your contusion versus your concussion. Okay, so these are two different terms, contusion versus concussion. Now, when I say, class, contusion, your cerebral contusion is the bruise that occurs when the brain surface would strike the inner surface of the skull. Okay, the big word there is bruise. And this is accompanied by small diffuse, okay, or diffuse venous hemorrhage. Okay, you highlight small and you also highlight venous. The problem in the contusion, class, is that there will be cerebral edema. Okay, and once there's cerebral edema, class, this would result to contusion, and then later on that would increase the blood pressure of your patient. Now, manifestations of contusion, or contusion, I mean, would involve depressed level of consciousness. So you have your confusion, stupor, then loss of consciousness. Patient may have dysphagia or aphasia, hemiparesis, which is weakness, or also paralysis, agitation or confused, but may be alert, focal or generalized seizure, and then you'll have your pupillary dilation. Now, when I say the word contusion, this is rare in occurrence but usually would render a person immediately unresponsive or partially comatose because of the significant brainstem disruption. You also have the term diffuse axonal injury. So class, when I say diffuse axonal injury, think of this that it's about a brain injury wherein there is high-speed acceleration and deceleration injury. Class, the widespread disruption of your axons in the white matter are due to the shearing and rotational forces. Okay, so that's why, class, you have diffuse axonal injury. In other words, it will be involving many parts of the it would be involving many parts of the brain. Then, class, injured area is usually diffuse. In diffuse axonal injury, there is no identifiable focal lesions. Okay, let's say, for example, your corpus callosum, cerebral hemisphere, and brainstem. Okay, there is no identifiable focal lesions. Immediate coma may result with no lucid interval, decorticate and decerebrate posturing, and global cerebral edema. Okay? Prognosis for this kind of patient tends to be poor, and then they may die or remain in persistent vegetative state. Okay? If ever they will be able to survive, they will be on a persistent vegetative state. Now, brainstem injury is also a part of your DAI. Okay, DAI is your diffuse axonal injury. Hemorrhage is not always detectable for these patients. However, rotational forces and shearing of vessels in the upper midbrain may cause this one, okay, leading towards acute midbrain hemorrhages. Okay, so class, the peak effect of hemorrhage or edema would be within less than 1.5 day or 36 hours. So you have 18 to 36 hours. Okay, brainstem injury, again, I would like to emphasize brainstem, medulla oblongata. So we're talking about here respiratory and cardiac function regulation. Now, your brainstem injury would result to deep coma from the moment of impact. Because other than the areas that I've mentioned, class, like your medulla, okay, what may possibly happen is that the pathway of the spinal cord going towards your cerebrum is also damaged, okay, leading to deep coma. Abnormal posturing, decerebration, or flaccidity may occur, okay, because of neuron damage. Pupils will be non-reactive. It may be even dilated. Impaired oculomotor responses. And then cluster will be abnormal respiratory patterns. Okay, your oculomotor responses will be related to brainstem and occipital lobe. Your abnormal respiratory patterns are related to the functioning of your medulla oblongata. Okay? Now, diagnosis. Diagnosis class of those conditions will be related to the history of trauma and then would be done by neurologic examination. And then, of course, your CT scan and MRI. Laboratory test will be looking at ABG for us to determine the need of the patient for ventilation and for us to determine whether the ventilation will be effective or not. Okay, then class, you'll have your CBC just for us to know the current RBC of your patient to determine for the presence of anemia. Okay, serum glucose will also be monitored. Okay, serum glucose will be monitored, class, because remember, there may be leakage of your CSF. And then other than that, your glucose is considered to be the food of your brain. Other than that, again, class, your hypoglycemia may delay the recovery of your patient. For electrolytes, again, I'm talking about sodium. And for osmolality, we monitor for both hypo and hyperosmolality. EEG, again, is for seizure. And then class, for your lumbar puncture, okay, that is done to diagnose if there are abnormalities in the CSF, particularly in an infectious process. Now, class, in concussion, your patient needs to be observed in the emergency room for 1 to 2 hours. Okay, in the usual experience, I would see doctors who would have the patient be observed in the ER for 12 to 24 hours. Okay, or sometimes we would admit them briefly in the room for them to be monitored for any neurodeficit. Okay, after that class, they would be discharged home with instructions. Okay, so again, the purpose of the admission or observation is just for us to check if there are neurodeficits. If there will be none on the next 2 hours as per the textbook, or none, okay, for 12 to 24 hours, we discharge the patient with instructions. The firm instructions that we will be giving the patient is that anytime there is dizziness, headache, anytime that there will be projectile vomiting, anytime that there will be brief loss of consciousness, or any untoward signs and symptoms, they need to go back to the hospital. Okay? If the loss of consciousness class was greater than 2 minutes, the client will also be advised for admission. Take note, class, that the CT scan of a patient who had concussion or contusion may still appear clear, class, on the first hour it is done. Okay, however, if your patient had the signs and symptoms already, and then class, a repeat CT scan will be done, usually the abnormality will already be visualized. Okay, oftentimes we encounter that the concern of the patient is still developing. When I say developing, okay, it's not yet there, but it is about to be there, so you need to observe your patient for its complications. Then, for your DAI or contusion, okay, that would require hospitalization and close observation for secondary effects. Okay, they would usually insert your ICP monitor probe in the purpose, of course, of measuring your intracranial pressure. Then we give your steroids. Okay, the purpose again of your steroids is to decrease cerebral edema. And then class, we're giving your osmotic diuretics also. Okay, the purpose of your osmotic diuretic again is to pull up, okay, the fluid from inside the brain going towards the intravascular space. Then, for severe head injuries, the management will be, of course, IV. Okay, class, when you're dealing with any injury, the next priority after you do the ABC is to facilitate the intravenous access of your patient. Okay, class, it will be the intravenous access that will allow you to administer immediate intervention on the part of the patient. If you are dealing with an adult patient, it is recommended that you will be using gauge 18 when you are cannulating them, especially that they are bound for surgery. Okay? Now, enteral or parenteral nutrition may be given to the patient. Okay, usually for long-term purposes, they would appraise you for a gastroscopy tube or gastronomy tube. Okay, then you also have your positioning. Okay, patient would not want complications related to immobility. Hence, proper positioning is needed. Then, of course, you have your passive ROM exercises. So, class, for the nursing care of this patient, look at the possible nursing diagnoses. Okay, almost the same. So you have ineffective airway clearance, risk for ineffective breathing pattern, pain, impaired thought process, altered cerebral tissue perfusion. Then you have your impaired verbal communication, bowel, urinary incontinence, and sleep pattern disturbance. That will be the end of your discussion in this topic. The succeeding topic class will be talking about your intracranial hemorrhage. Okay, thank you very much for your attention.